Welcome to the NWATC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Brian Wood, our medical director, to introduce our guest.
Great. We're very lucky to have Christine Udels-Flores with us today to talk about HIV and addictive disorders. Dr. Udels-Flores has been a part of our expert echo panel, so you'll be familiar with her, and she is an associate professor in psychiatry and director of psychiatry at our Madison Clinic. So thanks, Christine, for being with us.
Thank you very much, Brian. It's nice to be here. And today we're going to talk about HIV and co-occurring addictive disorders. I'm a psychiatrist, but I'm also a specialist in addiction medicine, so I like to spend half my time talking about mental health and half the time talking about addictive disorders. And today I'm going to talk a little bit about types of addictive disorders that we find in HIV and focus a little bit more on methamphetamine dependence. First of all, about 44% of adults living with HIV have either alcohol or other drug use disorders, and that is of course much higher than the general population. Those people who have alcohol and drug use disorders have a higher likelihood of engagement in risk behaviors. They have a higher amount of non-adherence with heart treatment, faster decline. There's a higher percentage of hepatic complications. And there is evidence that substance abuse treatment are effective in reducing these consequences. I think another big issue is they also have higher viral loads, and they're more likely to infect their sex partners when they don't use protection. So specifically, when you talk about substance use disorders, they've seen in large epidemiological studies that about 40% of people with HIV report using an illicit drug other than marijuana over the past 12 months. And with specifically with drug dependence, that's the DSM for diagnostic criteria. When they meet diagnostic criteria for drug dependence, about 12% screen positive during the previous 12 months. And that is 4 to 6-fold over the general population in the United States. Alcohol use disorders, it's about 2 to 4 times as high as among the general population, so that depending on the study that you see, it ranges from 8% to as much as 41%. And of course, those ranges, obviously, it's a very big difference, and it totally depends on what clinic you're seeing the patients in. Screening for alcohol use in primary care settings is very important, but screening in HIV settings is extremely important as well. And I know it's hard to do. There's so much you have to screen for in our HIV patients. So the National Institute on Alcohol Abuse and Alcoholism has recommended a single question that's very easy to ask in the primary care setting, and that is, how many times in the past year have you had X or more drinks in a single day? And X is 5 for men and 4 for women. So anytime the answer is yes, they should probably be screened further with an audit or a cage. And that single question screen is about 82% sensitive for the detection of unhealthy alcohol use, and it's even more sensitive but less specific for the detection of a current alcohol use disorder, that is alcohol abuse or alcohol dependence. CAGE is very common, very popular. We have the CAGE 8 as well that is more specific for drug use. But the single question screening test for drug use in primary care is, again, one single question, and it's how many times in the past year have you used an illegal drug or prescription medication for non-medical reasons. And that is 100% sensitive and almost 75% specific for the detection of a drug use disorder. Let's switch to methamphetamine. It's highly prevalent in MSM, and there's very strong associations between methamphetamine use and HIV-related sexual transmission behaviors. One of the studies I read here in preparation was that it's about 20 to 23 times fold higher in people with HIV than it is in the general population, which is amazing. And there really is a stepwide increase in HIV risk behavior and HIV studies. I mean, HIV positive people, it's the risk of using methamphetamine, the risk of becoming HIV positive is just increases in a stepwide fashion with the amount of methamphetamine that they use. And I'll talk a little more specifically about that. There is also a lot of evidence that behavioral treatments do produce sustained reductions in methamphetamine use as well as in risky sexual behaviors among methamphetamine-dependent MSM. So really we should be screening for meth use in any MSM population who seeks any type of medical treatment. Okay, here's a scary slide. Stephen Shoptaw, who's a psychologist at San Francisco General, and his colleagues have done a multitude of studies looking at methamphetamine use in HIV-positive people. And in this one study, they looked at MSM in LA County. And so they looked at street outreach services and looking at methamphetamine use and HIV positivity in people now this is people in like bathhouses, in sex clubs, and other places like that. And they saw that the prevalence rate among MSM who mentioned recent methamphetamine use was about 23%. When they further questioned, they found that if people used methamphetamine at least once a month for 6 months, their positivity increased to 42%. In those MSM who were actively seeking intensive outpatient treatment for their methamphetamine dependence, the rate of positivity was 61%. And in those who were seeking residential treatment for methamphetamine dependence, it was an 86% positive rate. So that's pretty astonishing, pretty scary. That's the stepwide fashion of increase that you see when you look at escalating use of methamphetamine. Now, methamphetamine psychosis is commonly seen in those who use methamphetamine a lot. And there have been some Japanese studies looking at methamphetamine use, and there's like a 40-year history of various methamphetamine epidemics in the Japanese population. And so they've seen in long-term users the rate of psychosis can be as high as 76 to 92%. We haven't seen that here, but we don't have as 40 years of methamphetamine use either. So the period of latency between initial use and onset of psychosis varies tremendously, and it's influenced by how much meth they use, how they're using it. So, are they shooting it up versus smoking it versus just eating it? And also, it also varies by individual vulnerability to psychosis. So some people can get away with a lot of methamphetamine use and not develop psychosis, and other people after 1 or 2 uses of methamphetamine will start developing some psychotic symptoms. And the psychosis is interesting in that there's this progressive alteration in mental symptoms from non-psychotic to pre-psychotic to severely psychotic in people who are methamphetamine dependent. And lots of times you don't see it unless you really ask specific questions. And I often see it in just suspiciousness and paranoia, and it will get worse. And that to me is the first sign that something is going on. And it doesn't happen just when they're intoxicated, because there's something called sensitization to methamphetamine that occurs, and that's we find that when people are withdrawing from methamphetamine, they tend to be just as psychotic as when they're intoxicated with methamphetamine once they develop methamphetamine psychosis. And there's this sensitization that goes on in that as the psychotic symptoms will generally gradually go away, but as soon as they use meth again, it comes right back, quite quickly, in fact. And there's that very long duration of vulnerability to relapse. Usually, persecutory delusions is the most common symptom of methamphetamine psychosis. But there's also a lot of people who have auditory hallucinations, and even more negative symptoms of schizophrenia is common. So they can appear just as if they have schizophrenia. When someone is under the influence of methamphetamine, you see that their movements and their actions appear very exaggerated. They might have darting eye movements, quick, jerky body movements. There's overstimulation and restlessness in their behavior. And they usually have rapid speech, scattered thinking, as well as paranoid thinking. They're also very labile, and easily irritated, can be hostile at times. And formication, or the delusion of insects or bugs crawling under their skin, is very commonly seen in people who have methamphetamine dependence. So it's often called crank bugs or meth mites. And they tend to scratch a lot at their skin, picking at their skin, and oftentimes dermatologists will see this. So, tweaking is when people are coming down off of methamphetamine. And as the effects of methamphetamine go down, they enter into that tweaking stage where they're more prone to violence, delusions, paranoia, and dysphoria and anxiety. This is, oftentimes after a methamphetamine binge, so oftentimes they haven't slept for days, they're extremely irritable, they're very restless, and they have intense craving and definitely increased hostility in that stage. Methamphetamine is associated with hostility and aggression. There's high rates of interpersonal violence, high rates of ER, trauma center visits, assaults, and weapons charges. And a lot of meth dealers, manufacturers will possess and carry firearms. So there's increased risk for homicide in people who are using methamphetamine dependence. Washington State Patrol statistics have seen that 50% of automobile methamphetamine seizures have also had weapons in the car at the same time, for example. And there's a recent study that looked at odds of committing a homicide, and they found it was 9-fold greater for an individual using methamphetamine, and that association persists even after adjusting for every possible other situation. For example, they adjusted for alcohol, for opiate use, for crack, cocaine, and hallucinogenic use. They adjusted for sex, race, military experience, previous arrests, and educational level, and methamphetamine was really the only drug use variable that was strongly correlated with homicide. Methamphetamine treatment is possible. People do recover from methamphetamine use, although usually addiction treatment programs report that they believe that methamphetamine treatment requires longer and more intensive treatment. So they tend to be more likely to succeed starting in inpatient addiction treatment programs and then progressing to outpatient after their inpatient period. And once they actually get in treatment, and they are as likely as other addicts to complete the treatment program. In Snohomish County, for example, almost 40% of methamphetamine-dependent addicts successfully completed outpatient treatment, in comparison to 52% of alcoholics completing treatment, which is pretty good. Now, treatment. Is there a drug to treat methamphetamine dependence? That's the big burning question, and there is no FDA-approved agent. There's a lot of studies going on, and there's some of the positive studies that we've been seeing look at mirtazapine, bupropion, modafinil, and naltrexone. So there's some suggestion that these might be helpful in conjunction with outpatient treatment or inpatient treatment. Anyways, we do use atypical antipsychotics for methamphetamine psychosis. There is some evidence that can prevent the methamphetamine-induced psychosis from becoming permanent if you put them on atypical antipsychotics. And we do use antidepressants for that dysphoria and depression that occurs after people stop using methamphetamine. 12-step support groups are very important, especially in urban areas where they're very common. And we have Strength Over Speed 12-step groups. There's Crystal Meth Anonymous 12-step groups. And there's, of course, Narcotics Anonymous and AA groups that, and lots of gay-friendly groups that we recommend that our patients with methamphetamine dependence attend. They also develop a support system with other people who are trying to stop, and that can be helpful because of that sober support network that they develop is very important for maintaining abstinence and preventing relapse. In terms of psychosocial behavioral treatment, that's still the mainstay for methamphetamine dependence, and there's the matrix model, which is using either cognitive behavioral therapy and or motivational enhancement therapy, and CSAT and UCLA have done studies, and it seems to be quite effective. In fact, cognitive behavioral therapy is the recommended therapy. But there's another therapy that's very interesting, is contingency management, and that's a positive reinforcement. And there's been really positive results in those contingency management studies. In fact, there was one specifically done for HIV positive individuals. There's been several looking at that, and that's when people, they get vouchers and rewards for providing urine tox screens that are negative for methamphetamine, and it does seem to be quite effective. It's also effective in people with mental illness, which is interesting. Contingency management seems to work. Drug court involvement is very helpful. That is coerced treatment, and when I was studying and becoming a psychiatrist, we were sort of taught that coerced treatment doesn't help. People have to be ready to change before they're going to change. But the incentive of not going to jail or prison is very, very high. And drug court involvement also includes case management and outpatient and inpatient therapy. So we find our drug court clients are very successful in stopping their use of methamphetamine as well as other drugs and alcohol. So I'm going to show you this last slide, which I think I'm excited about this. And this is, Mirtazapine, use of Mirtazapine to reduce methamphetamine use. And this was a randomized controlled trial. I know it's sort of hard to see this slide, but hopefully you can see it at home, or blow it up or something like that to read it. Or actually, I recommend that you actually look up the article because it's fascinating. And they saw that, they found that the need to treat, the number of people needed to treat to achieve a negative weekly urine test was about 3.1, which is pretty good for methamphetamine dependence. And so, and this was 30 people using methamphetamine, all using methamphetamine, 30 people using Mirtazapine, 30 people with placebo. So they also found that adherence was maybe 50%, although it was 75% by self-report. But the secondary results of this study were even more interesting than the primary results, in that sexual risk behaviors, basically all of the sexual risk behaviors, significantly decreased in those who were using Mirtazapine. And it decreased very significantly. It was quite amazing in terms of a number of episodes of anal sex with serodiscordant partners, the episodes of unprotected anal sex with partners, the episodes of number of male partners, and all of that decreased significantly. And so the conclusion was that, adding Mirtazapine to substance use counseling definitely decreased methamphetamine use among active users, but it was very associated with decreases in sexual risk behavior, even if medication adherence wasn't that good. And so I'm sort of excited about that. Of course, we have to think about what happens if we add Mirtazapine to antiretroviral treatment. And we have come up with another new problem, which is, of course, metabolic syndrome, because Mirtazapine can cause weight gain. And so we have to really caution people about that and recommend exercise. Which, and of course, people who use methamphetamine, as soon as they stop using methamphetamine, they also get a lot of weight gain as well. So they tend to get pretty thin. So that's all I have. If anyone has any questions.